Welcome to The Explainer. Today, we're doing something a little different. You're the surgical candidate, and I'm your examiner. We're diving headfirst into a high-stakes viva exam simulation. So take a deep breath. Your time starts now. All right, candidate, let's get right to it. The clock is ticking. You're presented with a 56-year-old woman. She's had a swollen, painful breast for about 6 weeks. Tell me, right off the bat, how do you approach this patient? Examiner, my approach will be systematic. The very first step is always a thorough clinical assessment. That means starting with a really detailed history and then moving on to a focused physical examination. Okay, examiners, so digging into her history, a few things really jump out at me as red flags. She's 56, postmenopausal. Her symptoms have been going on for 6 weeks. But here's the kicker. She was given a course of antibiotics and they did absolutely nothing. That right there makes me highly suspicious that this isn't just a simple infection. The history of hormonal therapy and her diabetes are also important pieces of the puzzle for her overall risk profile. Now for the physical exam, the findings are, well, they're pretty alarming. Her left breast isn't just swollen and red. It has that classic puter-orange look, like the skin of an orange. That is a massive textbook red flag. I can also feel a hard 4-centimeter mass that seems stuck to the skin, and there are definitely palpable lymph nodes in her left armpit. Based on this, my #1 suspicion by far is inflammatory breast cancer. I'd also keep a breast abscess or another advanced cancer on my list, but IBC is at the very top. Very good. A solid clinical assessment. So you have your primary diagnosis in mind. Let's move on to how you're going to prove it. With these worrying clinical findings, what's your immediate next step? How do you work this up? My next step is to perform a triple assessment. It's a standard protocol. First, we get imaging. That's a bilateral mammogram and an ultrasound. Second, we need tissue. So I'll do a core needle biopsy of the breast mass. And third, we need to check those nodes. So I'll perform a fine needle aspiration, an FNA of those suspicious lymph nodes in her armpit to see if the cancer has spread. Very well. Your investigations are done. And here are the results. The breast biopsy confirms a grade 3 invasive ductal carcinoma. Receptor status is triple negative, and the Ki67 is high, at 60%. Your axillary FNA came back positive for malignant cells. So, candidate, what is your interpretation of these findings? What does this all mean? Examiner, this pathology report paints a picture of a very aggressive cancer. Being triple negative is a known poor prognostic factor, and a high Ki67 tells us these cancer cells are dividing very, very quickly. Putting the clinical picture together with this biopsy, it confirms my leading diagnosis: inflammatory breast cancer, or IBC. Correct, you've nailed the diagnosis. So now you have to figure out how far it's spread and come up with a solid, comprehensive management plan. My initial management plan has 4 absolutely critical components. First, and honestly most importantly, is to sit down and break this terrible news to the patient with compassion and clarity. Second, I'll order staging scans, a CT of her chest, abdomen, and pelvis, plus a bone scan to check for any distant spread. Third, this case is complex, so it absolutely must be discussed in a multidisciplinary team meeting. And fourth, the primary treatment for IBC is neoadjuvant chemotherapy, meaning we give chemo before any surgery. Okay, good. The staging scans come back and they are negative. There's no sign of distant disease. Tell me, what is her precise clinical stage? Her clinical stage is T4D, N1, M0. The T4D is the key part. T is for the tumor, and the T4 designation is specifically for inflammatory breast cancer. N1 means there's nodal involvement in her armpit, and M0 means no distant metastases. You put all that together, and it makes her stage 3B. All right, let's move forward. The patient completes her neoadjuvant chemotherapy, and she has a good response. Now we need to talk about the definitive surgical plan. The patient is feeling hopeful after her good response to chemo. She looks at you and asks, "Doctor, does this mean I can avoid a mastectomy? Can I have a lumpectomy instead?" What do you tell her? My answer to her has to be a very clear, but also empathetic no. I would explain that unfortunately, breast-conserving surgery is an absolute contraindication for inflammatory breast cancer. And this is a huge exam point. It's because the cancer cells are spread diffusely throughout the skin and the lymphatics of the breast. So even with a great response to chemo, there's no way to guarantee we've gotten it all without removing the entire breast. And of course, as part of my consent process, I would carefully walk her through all the potential complications. I'd cover the general risks that come with any major surgery, like blood clots or pneumonia, and then I'd cover the specific risks of a mastectomy and axillary dissection. Things like wound infection, fluid collection called a seroma, skin flap issues, nerve injury, and the long-term risk of lymphedema, which is that chronic swelling of the arm. Excellent. But in any board exam, you have to be ready for a twist, a curveball. Let's see how you react when things don't go according to the textbook. Okay, let's rewind. Remember those initial staging scans? Let's say they weren't negative after all. In fact, they revealed a single metastasis on her L4 vertebra. How does this one finding completely change your entire management plan? Examiner, that finding, that's a complete game changer. It changes everything. The presence of even one distant metastasis automatically upstages her to stage 4 disease. This means our treatment goal fundamentally shifts from being curative to palliative. The focus is no longer on aggressive local treatment like surgery. Instead, it becomes about systemic therapy to control the disease everywhere, manage her symptoms, and preserve her quality of life for as long as possible. Very good. Okay, for the last question, let's go back to the original scenario, no metastasis. What does her long-term follow-up look like? My plan would be a clinical review with a history and physical exam every 6 months and an annual mammogram on her other healthy breast. And here's another key exam point. We do not perform routine staging scans on asymptomatic patients. There's just no evidence it improves survival, so we avoid the unnecessary radiation and anxiety. And that concludes our virtual Viva. If there's one thing to take away from this case, it's this. In complex oncology, having a systematic multidisciplinary approach isn't just a good idea, it's the only way. It takes a scary, chaotic situation and turns it into a clear, manageable pathway. The real question is, how can we apply that kind of structured thinking to every complex problem we face? Thanks for watching The Explainer.